A 45-year-old male presents with progressive chest pain following minor trauma. I'm showing you the chest radiograph. Describe the findings.
Okay, looking at the images. The chest radiograph demonstrates multiple bony exostoses arising from the ribs bilaterally. There is a large lobulated soft tissue mass projected over the lateral thorax. Additionally, there is a small pleural reaction and multiple well-defined pulmonary nodules of varying sizes in the upper and lower zones, suspicious for hematogenous pulmonary metastases. The presence of multiple exostoses is characteristic of Diaphyseal Aclasis, and the large thoracic soft tissue mass and pulmonary nodules strongly suggest malignant Sarcomatous transformation with pulmonary metastases.
What is the pathophysiology of Diaphyseal Aclasis, and how does malignant transformation manifest?
Diaphyseal Aclasis, also known as multiple hereditary exostoses, is an autosomal dominant condition characterized by the development of multiple osteochondromas. These are benign, bone-capped cartilaginous lesions arising from the metaphyses of long and flat bones. Although benign, osteochondromas can undergo malignant transformation into secondary chondrosarcomas or osteosarcomas in less than 5% of cases. This malignant degeneration typically occurs after skeletal maturity and is characterized by new-onset pain, growth of the lesion, cortical destruction, and thickening of the cartilaginous cap.
I am showing you radiographs of the forearm and the femur. Describe their findings and how they relate to the disease.
In that case, the anteroposterior and lateral radiographs of the forearm demonstrate multiple bony exostoses arising from the metaphyses of the radius and ulna, pointing away from the nearest joints. There is associated ulnar shortening and bowing of the radius, representing a pseudo-Madelung deformity. The radiograph of the femur reveals a large osseous lesion arising from the medial femoral condyle with extensive flocculent, popcorn-like calcification. This calcification pattern is characteristic of a high-grade chondrosarcoma arising from a pre-existing metaphyseal exostosis, further illustrating the risk of sarcomatous transformation in these patients.
What radiological features help differentiate a benign osteochondroma from one that has undergone malignant degeneration?
Well, the most critical imaging feature of malignant transformation is the thickness of the cartilage cap. On magnetic resonance imaging, a cartilage cap thickness exceeding 1.5 centimeters after skeletal fusion is highly suspicious for malignancy. Other concerning features include rapid growth after skeletal maturity, progressive osseous destruction, a new soft tissue mass, and a change in the mineralization pattern on radiographs, such as new lucent areas or dispersed flocculent calcification within the cartilage cap. Clinical findings like pain in a previously asymptomatic exostosis are also highly supportive.
How would you manage this patient as a radiologist?
Okay. As a radiologist, I would recommend comparing these radiographs with prior studies to document the rate of exostosis growth and assess for new cortical erosions. I would suggest obtaining a dedicated chest CT scan to fully characterize the pulmonary nodules and evaluate the thoracic exostoses. I would also recommend an MRI of the chest wall and the forearm to measure the cartilage cap thickness and assess for soft tissue invasion. I would immediately communicate the findings of chest wall mass and pulmonary nodules to the referring team and recommend urgent referral to a specialized sarcoma multidisciplinary team.